So welcome to the third in the series of occasional webinars on business process modelling in health and care. Thank you very much for joining us. It's much appreciated. I'm Mike Anderson. I'm the Technical Standards Lead on the Health and Care Executive in the BCS. And I've been organising this group of webinars with Tito Castillo and Charlie McKay, to whom many thanks as well. We're recording this session and it will be put on the BCS website and onto YouTube in due course. And you can also see the previous webinars that we've held in the series on there too. Before I hand over to Nicholas, I'd just like to say that we're hoping to make the webinars a bit more regular. It's been a slightly difficult year, obviously. And in the autumn, we hope to have a series of them. And we're also looking for speakers for those. And I know there are one or two people who are on this webinar who probably have some expertise that we would welcome. And if you'd like to get in touch, if you'd be interested in speaking, then just please drop an email to groups, groups at bcs.uk. That's groups at bcs.uk. And just mention that you'd be interested in speaking. And I'd like to extend that invitation not only to people in the UK, but if they've joined, I know there were a few from the States who had booked in, so please feel free to get in touch. I don't think I've got anything else to say by way of introduction, so I'll hand straight over to Nicholas, who's going to tell us how CONTSYS can help you in your business process modelling. Over to you, Nicholas, and thank you very much for agreeing to do the talk.
Oh, thank you, Mike, and thank you for that introduction. I guess I probably ought to go and say a little bit about myself ahead of the main content. I'm Nicholas Altibridge. The day job is as the lead architect for NHS England, based out of Leeds. I tend to wear a few hats though, so I'm also the chair of the BSI committee for health informatics, and in that role have also been the lead for the development of the CONTSYS standard within the ISO community since about 2010.
Sorry, Nicholas, just before you go on, I forgot to say something fairly important. Thank you, Charlie, for reminding me. Yes, the way we're going to run this is that if you have any questions as Nicholas is talking, please put them in the chat. If they're questions of clarification, we'll answer them as he'll answer them as he goes along. But otherwise, we'll have a Q&A session at the end and we'll go through the chat and see the questions that have come up. Sorry, Nicholas, I forgot to mention that.
No, that's fine. And it is indeed on the slide, so we'll pick that one up. But yes, if you can put any questions into the chat rather than asking them directly, just so that we don't directly disturb everyone. In terms of topics for today, then I'm looking at describing the background to the concepts, where it came from, then focusing on some aspects of that, particularly around the clinical process, since the process is probably the most relevant to BPM. And then the concepts which are supporting that, not the whole of the model, because I think that would take far too long, but the key ones that are relevant and the kinds of concepts that are relevant. Then linking in with how it fits up with a joined up health and care system, because with a standard which is a system of concepts for the continuity of care, continuity across healthcare providers, across organisations, across specialties, across teams is really important. Then I'm going to go on to talk a little bit about what's next for the standard and where the standard is going. And then we'll open it up for probably about half the time, which should be a discussion. That assumes that people are willing to ask questions and to engage in discussion. If you don't, that might be a smaller part of the section. And you might be able to go and have your tea a bit earlier. So the system of concepts is describing how health and care is managed and delivered across the globe. It is an ISO standard concept model, and as such has been reviewed and endorsed across the globe. Health and care delivery across the globe tends to be quite different. If you compare the funding models in different countries, they're very different. But the clinical process that people follow is remarkably similar, whether it's in Europe, UK, United States, Southern America, China. They all follow a very similar process. The system of concepts itself has been separated into some groupings just to make it a bit more digestible. The healthcare actors, the people involved and the organizations involved, healthcare matters, what's wrong with people, healthcare activities, things that we do to people, the process itself, planning for that process, time, responsibilities, and finally information management, which is where the healthcare record fits in. So although it's a healthcare informatics standard, the healthcare record is just one small part of the system of concepts. So what is it? It's an internationally agreed standard. It's a full international standard approved by ISO. It's a model of how the health and care business works. So if you think about an architecture framework like TOGAF, then it's very much describing the healthcare business. It's been approved by both ISO and CEN. It started off in CEN, the European standards organization, and was then broadened out to become a full ISO standard. So what does it provide? It's fundamentally, it's a list of terms, definitions for those terms, notes and examples on how those terms should be used, and probably most importantly, the relationships between the different terms. This is quite abstract at the moment, but I'll go into much more detail very shortly. Importantly, it's also a resource to help IT people understand the clinical business using those concepts, definitions, relationships with multiplicities, so that a formalism that is familiar to many people in UML is accessible for the IT people, but is also one which has had good clinical review in the whole of the standards process. It's probably fair to say it's also probably around 20 years old since it was initially conceived. Importantly, it's not a data model. So if you're looking for attributes of things, if you're looking for data types, strings, integers, generic timestamp for those of you into the HL7 space, it's not going to be in CONTSYS. Equally, it's not a vocabulary that is in any way trying to compete with SNOMED CT. CONTSYS has got around 100 concepts in it, and it's describing the business. SNOMED CT has got something like 400,000 concepts within it, and they're broadly talking about the detail that would be represented to describe some of these concepts for an individual patient. So some places where it's been used in the standards space, ISO 13606, which is the international standard for an electronic health record. You're probably more familiar with its sister specification, OpenAir. In the ISO 13606 standard, it's used for the reference archetypes, effectively the domain models for the health and care process. It's also used within the International Patient Summary. The International Patient Summary is a standard of the pertinent facts that you would expect a clinician or a patient to be able to view anywhere in the globe if they chose to do so. And all of the G7 nations, the group of 7 nations, have committed to make the International Patient Summary available to their citizens to take overseas when they go to different countries, and so they can share that. And I guess the other thing that's probably relevant for my day job is that it will be the underpinning business model for the next version of the NHS Data Model and Dictionary, datadictionary.nhs.uk. The current business model, the meta model, is quite hidden within the data dictionary, but if you search the data dictionary for the term meta, then it does get exposed. When CONTSYS goes into the data dictionary, so we go from version 3 to version 4, then it will be much more evident within there. Just talking about the dictionary itself, that's been around since 1985. We're now on the third version of the model, which came in 2005, and the next edition of that is something that we're just starting to look at how we would build that. So it would be inappropriate not to have some examples of concepts right up front. So health need is the one I've chosen. So here you've got an example from the standard itself, as displayed on a website that I provide the global community. And its definition: the deficit in the current health state compared with all aspects of a desired future health state. My way of looking at it very much around what would I like to be better about myself. When you look at the model, you then see health need in the middle of that particular diagram, and you've got all of the relationships to other things. Health state's a really interesting one. That is that remarkably ephemeral thing. How are you today as a person? It is, of course, an answer you can never answer. You do not know all of the different aspects of your body, or how your body is working, how your mind is working, how your emotions are working. We're often completely unaware of them individually, but equally, they're not things that are easily measured, many of them. So the health state is one of those things that exists, and it's an important concept, but it's not something that you can measure or quantify. Subject of care, the person that the care is all about. In healthcare, we tend to call them a patient. There's all sorts of different language used. Sometimes it's a client. And those pseudonyms do exist on those concepts. The objective, what we're trying to achieve. The needs assessment, that's an important process, and the activity described in the health needs assessment is the thing that then works out what do we actually need to do to go and help the patient to get into a better state, or how can we advise the patient to take steps to get into a better state, to improve their health state towards that desired future health state. Needed healthcare activity is probably one of the most significant ones, and often gets confused with health need. And often in some disciplines like nursing, people will talk about a patient's needs. They're not the gaps in their ability, their health state. It's not, as a patient, I need to be able to go and tie up my shoelaces. It's the activities that people will perform to assist people to go forward. So health needs about what's wrong with you. Needed healthcare activity about the things that will be done to change your health state or to improve your health state so you're in a better position. And then you see some notes, and I'm not going to go through all of those today.
Nicholas, just before you go on, a quick point of clarification. That all says health all over. Is there anything? Health. Yes. Is there anything equivalent for other types of care?
So it's about health, not health care. Health is your wellness as well as your illness. And it's taken the definition of health in CONTSYS is coming from the World Health Organization Declaration on Health. And I'm not going to try and remember what that is off the top of my head on this occasion. And I can't remember whether it was in the browsable model. It may well be, and I will just go and check that when we go and have a look at it. But it's very much intended to be inclusive of social care, recognizing it's a standard within the healthcare informatics part of ISO, and not going outside that tight boundary that ISO provided. But it's taken this very broad definition of health. So it's all about your wellness as well as the activity that changes your wellness. But a very important question, right? So when we get to the clinical process, I said that the funding models and everything were very different across the health and care systems, but actually the clinical process was remarkably similar. And it comes down to assessing how someone is, planning to do things to change that, performing activities to learn more information on the red cycle or to actually change how you are on the blue cycle. And then a really important step that all clinicians do, they don't necessarily document any of these steps, but they all do them, evaluating whether or not what you were doing worked. So if you think about it in terms of a nurse walking down a ward, as they look at every patient as they're walking down that ward, they'll just have a quick look at them, check that they look okay. If they don't look okay, then they'll intervene to do something about it, or they maybe start planning. In the days of linen aprons, then they'd probably scribble down some notes onto the apron itself. Nowadays, they use a notebook or something like that. They may well do some interventions or do some investigations, and then, of course, they'll evaluate. And that spiral of, first of all, working out what to do, then going and doing it to change the health state is really important. And you see here that the input health state then goes through and becomes eventually an output health state. So in process modeling terms, we've got a clinical process here, which takes an input and transforms it to an output through a series of activities. We're doing that through this clinical process, the clinical cycle. The language in here is using the CONTSYS terms. In terms of that clinical process, then starting off with your input state, converting it to an output state, there is within that a whole fractal arrangement of processes which spin off to do individual parts of that clinical process. So processes call sub-processes, and that's just natural with any process orchestration. So those termed within termed healthcare processes within a clinical process, which is for the end-to-end care of a patient from beginning to an end for a clinical problem. So I'll flip over to the website I share. Hopefully everyone can see this cleanly. Someone shout up if you can't.
It's fine.
So this is the homepage for the concept, and again you see the same diagram in there. That diagram actually serves as a bit of an index page too. There is a search capability, so I'll just try the word health to see if I've got the definition of health in here. I can't remember if it is or not, and it is. No, it's not. It's not actually got the definition. It's just in to go and actually help with the modeling. So apologies for that. Going back to the home. So I'm going to start off by focusing on the clinical process, and then I'm going to also look at some of the other bits around that, and in particular, healthcare actors, healthcare matters, activities, and planning. I'm not going to look at time, responsibilities, and information management unless there are questions about that later on. But they are important things. And CONTSYS has caused quite a lot of concern when it went through its standards process because of the part on responsibilities. Because, for example, in the United States, there is one state where a clinician, I'm told, does not need a legal power to be able to treat patients. They can just do it without any legal power. And yet, in reality, we know that there needs to be a need there within any European system and the rest of the United States, to be honest. So when we go into the CONTSYS diagram, we end up with a list of all the different concepts on there. And in this case, we end up with a diagram too, with the clinical process at the heart of it. And again, you've got that input health state as an input to the healthcare process. And at the end of it, you end up with an output health state. So it's probably worth looking at some of those definitions and start off with the healthcare process. So very much based on the ISO definition of the process, it's a set of interrelated or interacting healthcare activities which together transform inputs into outputs. And in this case, it's transformed the health state from its undesirable state to a more desirable state. And again, we've got the those going through, and you've got the diagram there. I'm not going to walk through all of these diagrams and talk about every particular concept, you'll be glad to know. But when you look on each of these diagrams, you do get the tooltips coming up, so you don't need to go and click on things. Equally, if you do go and click, it's fully hyperlinked. Some of the important things around here, though, the clinical process, and that is that end-to-end one that is focused on a particular condition, what is called a clinical process interest. There is color coding going on, so the concepts about the clinical process are all in red, around the process side are all in red. So the clinical process interest there is effectively joining up all of the different activities that are to do with a particular condition. So if someone's got a relatively simple short-term condition, a transitory one like they get a cold, then it's a relatively short clinical process. It starts off with a bit of advice on what to do, don't use an antibiotic, etc. And then ends up when the patient feels resolved on that cold, typically about 14 days later. If it's a condition like diabetes, then the clinical process is going to carry on pretty much until that is resolved with a pancreas transplant, which is remarkably rare, or the patient dies. So the clinical process could be a really short process, or it could be a really long process. Importantly, in here, we've got the process evaluation, and that is enabling us to understand whether or not the work we're doing is doing what we intended it to do. You've got a few other things that are really important. So you've got adverse events. Things can go wrong. They can be because biology is kicking in and causing problems, or they can be because we actually mismanaged the patient, hopefully in rare events. One of the more significant concepts, though, is the healthcare plan. The care plan is there to actually work out where we're going to. And it's got the sister thing, which is the health record. I see very much the healthcare record as being about the history of what's happened, everything that has taken place for that patient as a documented ledger. The care plan isn't about the history, it's about the future. And I'm strongly of the view that we need to start moving away from a focus on the electronic patient record and move that straight over to the electronic care plan so that we can actually see where we're going rather than where we've been. So moving back into all the topics, I'll move over to healthcare matters. So the healthcare matters is basically the answer to the question, how are you, in a way that can be expressed. Some healthcare matters are things that are ones that we'd want to do something about. Many of them, though, are not. Something might, a healthcare matter might be something like, I live in Yorkshire. That's just a fact about me. It's not something that we're going to do anything about. I desperately don't want you to do anything about it. I enjoy living in Yorkshire. But there may be things which are health issues. And if there are health issues, then they're things that we are intending to do something about. And that then means that there's a set of responsibilities, and the healthcare providing organisation or person therefore is trying to help with specific issues about your care. They'll do that within a care plan. They may well follow clinical guidelines being something that maybe an organisation like NICE produces. There may well be episodes of care coming from the time part of CONTSYS, which are describing the time that a particular organisation is looking after you. And of course, underneath that, you may well have a healthcare condition. On the same page, we then go into a bit more detail, and you see that the healthcare condition gets broken down into a whole heap of different types of conditions. You've got, is it one that the professionals have assessed, or is it just one that the patient has come to conclude? It may well be a working diagnosis. What are you trying to go and treat? What is the assumption that you're making? It may well be a condition as a result of doing something. So you perform cardiac massage and the heart starts beating, that would be a resultant condition. There's also a set of conditions which are potential rather than real. That's potential desirable or undesirable conditions for the future. So it could be the prognosis, it could be the target where you're trying to get to. It could equally be a risk that you're trying to avoid. Quick move into, I'll skip the healthcare actors and let us have some conversation, but move into the planning side of things, because I think that's particularly relevant also to the BPM side of things. And with healthcare planning, we're looking at everything that then feeds into that care plan. I'm just going to reduce the screen slightly, apologies for that. So, really important one is the clinical pathway. How should we treat diabetes in England? How should we treat whatever the condition is in England? That's something which would come from an organisation like NICE. You then end up with local organisations. So the clinical guideline would come from NICE. The clinical pathway would then be informed by NICE. You then end up with a protocol, which would be a local implementation of a guideline. That local implementation may well then feed into some core care plans, and some core care plans would then enable us to have reusable content that gets used within the care pathway and the care plan. Importantly, in the middle of this, you've got healthcare planning, and that's very much a process activity, something that is actively done by clinicians. Documenting a care plan was a really important part of nursing from pretty much the 1990s onwards. We've got a few flavors of that, and we've got also that shopping list of activity that needs to be performed. So you end up with a bundle of activity, very much like a bundle in the pathology test space, and you've got the activities that kick in to go and deliver that activity. And all of these activities are trying to achieve a health objective and to do that through a set of healthcare goals. And what you're trying to do is to get to this target condition. How do I want to be in the future? So the care plan is very much focused on achieving those targets where we're trying to get to for the patient. So I'll flip away from looking at the model at this stage and then go into a few more slides, but not too many, you'll be glad to hear. So within the way I'm thinking of the data model in dictionary version 4, I'm seeing that we have a set of actors, the healthcare actors within the CONTSYS space. That could be the citizen, whether they are a subject of care or someone who is providing care to someone else. It could be regulated healthcare providers, So organisations, people who are given some power to go and provide healthcare, whether it's a CQC registration or potentially a professional registration. And it could equally be employed staff or volunteer staff who, whilst not being regulated by a regulatory body, are still empowered to deliver parts of care as part of an arrangement in the healthcare system. And really importantly, there's funding. And funding can either come from the public, it can come from self-funding, or it could come from some other source, for example, an insurance company. The clinical process itself is about taking in a referral, doing that assess, plan, intervene, evaluate cycle, and that then ends up in either setting off additional of those cycles in terms of requests for opinions or referrals to the other parties to take over from the clinician, or it leads to discharge, or it leads to death. And that can happen within a scheduled space or an unscheduled space. It can be something that is done under self-care or healthcare professional or healthcare organizational delivery. It can happen within the context of a contact, which is another CONTSYS concept, and it can happen during an admission, admissions being the time that you're spent within a hospital for care. And that process generates a data exhaust pipe, which we call the electronic patient record. And in that electronic patient record, you've got all of those actors, you've got all of the process activities, but really importantly, you've got a journal of all of the observations and findings that have been identified. You've got all of the investigations that have taken place, and you've got all of the different treatments. Whatever the treatment regime is, whether it's medical, whether it's medicines, whether it's devices, whether it's cognitive, whether it's surgical, and in some cases there's the preventive activities, and rather than being responding to a particular need at a particular time. And then all of those get joined together with what in CONTSYS is known as a health thread. And those threads are effectively, how do you join up the different stories? So you've got the story of the clinical process itself going from the condition start through to the condition's end. You've got the story of a particular healthcare actor being involved in that. So the story of the time underneath a particular consultant, or the time that a particular healthcare practitioner was looking after that patient, so that the healthcare practitioner can evaluate their own performance on different kinds of patients. And there'll be lots of other stories going on as well, which come out through these threads of interest.
Just before you move on, Nicholas, I don't know if this is a question of clarification or whether it's something,
Thank you, anyhow,
a discussion later, but Charlie's asked, should devices sometimes be actors, where the sometimes is in brackets?
So the view we took was that a device was always something that was not in itself liable but or responsible, but it was a human being or an organization that was responsible, whether that's the device manufacturer or the clinician who's chosen to use the device. It's a moot point, and there may be a point where we get to the point where we've got regulated devices where the device itself has some cognitive capability that is regulated, but at the moment the legislation globally doesn't really support that. So for now, it's not an actor. It was in the European original version, and it got moved out in the moved to the ISO version. So it's very much a very good question. I can always trust Charlie to ask those. I guess it's probably just worthwhile saying a piece of work that we're looking to do and came out in the draft standards for interoperability strategy, which is to be able to describe a common representation of what that care record that is the exhaust pipe would look like, and how that ties into these concepts. So we will be looking at making that much more clear as part of the work to get that data dictionary version for data modeling. That will also include the care record consequences for that one. And we also committed to use either the ISO 13606 or OpenAir or something else that the health community for England came up with. So taking on board the views of suppliers and healthcare providers and regulators and so on. So what's next? For the standard, the 2015 edition is currently in revision. I'm leading that piece of work, and we've split it into 3 different work streams. The 3 work streams are focused on, first of all, the social care side and population health. It's not that CONTSYS doesn't cope with those, but it doesn't call out in the language of social care some of the social care activities. So the concepts are the right concepts, but it doesn't actually use the labels that social care people would use. There are some examples where that's happened successfully. So I mentioned subject of care is also client, and that's much more care friendly. But there are cases where it isn't as cleanly called out, and it will be. The second ISO edition, when it comes out, will also be much cleaner on the links into International Patient Summary, FHIR, and ISO 13606. And there's some excellent work demonstrating that actually FHIR is using CONTSYS. It didn't really know it, and there are some areas where FHIR is different, or where FHIR is informing how CONTSYS should be, and there'll be links into FHIR from there, and consequently into International Patient Summary. For the ISO 13606 space, some of the concepts that define the reference information model in ISO 13606 will be lifted into CONTSYS to just flesh out that information management part. And then the third part, which is one that is in early stages and will go out as a separate report rather than as part of the international standard, is looking at how CONTSYS can be represented more ontologically, and how that can then tie into the Dolce top-level ontology, so that you can start doing some processing. And some work coming out of the Oxford University Hospitals NHS Foundation Trust will be looking at demonstrating how that ties together.
Would you just like to say a bit more about Dolce, because I'm not sure that everybody will be familiar with that?
I'm afraid you've caught me out to some extent, in that other than it's the top level ontology, and it may well be there's someone else who's much better in a position to go and talk about it than I am, I'm afraid, Mike, but I'm not going to go down that one.
Okay.
I'll look at the presenters, the attendee list shortly, and pick that one up. I guess it's appropriate to put out where to go for more information. Starting point, Wikipedia. The links, when I think we are making the slides available, aren't we, Mike?
We certainly are, yes.
And the links will be active links in when you get hold of them. The ISO website itself gives quite a lot of background information without actually giving the full details of the normative parts of the standard, but that does give you all of the introduction, etc. The model that I've been showing is available on contsys.org, the website. If you feel like it, you can buy the standard, but the vast majority of the content is available in other forms through the ISO website itself and through the model that conforms to the standard. And feel free to go and connect to me through LinkedIn if you haven't already done so. And I know some of you on the call are already connected there. So, any questions? And lots of discussion.
Well, thank you very much indeed, Nicholas. So that was remarkable for 2 reasons. Firstly, it's a fantastic piece of work. And secondly, that was a truly excellent talk about it, for which we're very grateful indeed.
Oh,
so thanks. We haven't had a huge number of questions in the chat as far as, unless I've missed some. But I should imagine that's because you had everybody fully absorbed throughout. But while we're waiting to see if we get any others, maybe I could just ask a couple. And you mentioned the International Patient Summary, the data dictionary, and the interplay with FHIR. Are you aware of any other ways in which CONTSYS is being used to, I don't know, improve healthcare or develop different ways of providing care? And if you're not, supposing somebody was trying to improve how their outpatient clinic was run, for example, could they use CONTSYS, and if so, how?
I think the answer's probably they'd use it indirectly rather than directly. It's clearly a resource that's available to people, and if you are building models of the way that your work is being executed, then it's a valuable resource for going to check that your model is solid, or indeed to inform that model. I'll give you an example from the days of Connecting for Health, actually, so going back some time. But the team were trying to work on a MIM version 3 specification to deal with assessments. So HL7 version 3, looking at assessments within clinics. And for that, they had managed to confuse the concept of an assessment with an assessment, same word used in two very different ways. Assessment, the verb, doing the assessing, assessment, the noun, the report that came out of the assessment at the end of it. Because they'd conflated those two, then the message didn't actually make any sense. But when they went and reworked it based on the CONTSYS concept model, then they got the clarity that they are two completely different things, and that then enabled them to get a much cleaner business process, and therefore the interactions and the models that came out of it.
Okay, good, thank you. Got a question from Katie Wheatley here. It says, do you know if the HL7 working groups take CONTSYS into account when developing the standard?
The answer is yes and no. It depends very much on the HL7 working group. There is work, and HL7 people are very much engaged in the same space, or people who are in the HL7 communities are also in the CONTSYS community. But equally, HL7 is a large and diverse organization and comes up with large and diverse answers, some of which are sensible.
Indeed, yeah. Right, question from Tito. Can Nicholas please expand on the challenge that he outlined earlier to enable electronic care plans to see where we are going rather than where we've been? What do we need to do to enable this? And that's a very good question. I was quite struck by your comment about focusing on the care plan rather than the electronic health record.
There is a big challenge here in terms of the information technology systems that hospitals buy and other organizations buy tend to be focused on an organizational focus rather than a integrated care focus. And they tend to be focused on documenting what's happened rather than where we're going to. One of the things we need to do is to make certain we can express the plans, the intentions that will get documented in the care record with a status of something that's future cast. But to do that in a way which is much more shareable. At the moment, the standards for sharing that information and also the ability to bring all of those into a common view are really difficult. We don't have a clean answer to that question yet, but it's one that in NHS England we recognise is a significant problem and are actually looking to recruit people at the moment to go and take it forward. So we're just about to re-advertise some roles that we had advertised until NHS England announced that it was just having one of its regular reconfigurations. But they got paused for a week, but hopefully tomorrow or so we'll end up with those back available for people to go and join our team and really take part in that enjoyable work. There's details on my LinkedIn page for those who are interested.
I was just about to say, do you want to put that into the chat? But I dare say the LinkedIn page will do.
Yeah.
Okay.
It's great to hear, Dennis. If we're looking for someone who understands how BPM and DMN can fit together, then Dennis is the guy.
Indeed. Anyway, yes, so his question is CONTSYS available in various electronic formats?
So on the website that I've demonstrated, it's available as a SCOS vocabulary with the relationships in it. And I believe it's contsys.org/RDF to get a hold of that one. It's also available if you contact me. Then the Norwegian Health Directorate did the UML model that is driving the website, and that diagram is available as a XMI export from their tooling. UML is universally readable, but the XMIs are universally platform specific. Thanks, Dennis.
Yes, that seems to have given you one happy customer, so that's good. Okay.
He probably wants me to be his happy customer.
Yes, so, well, there is
which
that.
I would love to be in the right time.
Yeah.
Cheryl's got a hand up too.
Right, well, we could probably, since there's only a few of us on, open that up as for her to speak, if Tito would like to do that.
Or maybe not.
Can you hear me?
Yeah, we can hear you now, yeah.
Oh, there you go. No, it's all right. We didn't have to. We can unmute ourselves.
Right,
okay. Total control. Yes. Nicholas, hello. Hi.
Hello,
I haven't seen you for a very long time. But can I go back to the discussion that was starting to be had about care plans?
Yeah.
Because this is something that I'm deeply involved in, and have quite a lot of examples of integrated care plans, which I'd be happy to share and discuss with you, actually, if you'd find that useful.
I would find that helpful, yes, Cheryl. And I think the notion of a genuinely cross-organizational care plan where people can use their operational systems as they would normally, but actually that what they're thinking, what they're planning becomes available is probably the key to unlocking efficiency in the health and care system.
I totally agree with you. So I'd really love to have that conversation. So and we've got lots of examples in operational use right now where the care plan's contributed by many different organizations. Let's say if you think about the constellation of care for an individual patient.
Absolutely. Yeah.
Everybody that's looking after that person will use the same care plan. And for care planning purposes, but the detailed care record is for detailed care stuff.
I think that's right, yeah.
For those, yeah. So it would be good to have that if you're interested. Yeah, we've got each other's contact, but I'll make contact with you.
And care plans are very fractal as well. You end up with the thing that contains all of the activities, but probably doesn't want to be in the in the fine grain detail. And then you've got the individual, even down to I've got the plan that I need to take some medication once a day in the morning, and that's part of a plan.
Exactly, and it's about keeping things in context.
Yeah,
and context can be lost in a massive record, in a healthcare record. So yeah, great.
Oh, thank you, Cheryl. Does anybody else have any other questions? As you can tell, you can unmute yourselves or you can put them into the chat. And if not, there's one other thing that I'd quite like to ask you, Nicholas. It's a bit English specific, but you did say that there was likely to be a revision of the data dictionary the NHS data dictionary based on this. Does that mean a wholesale change? What are the backwards compatibility implications? The NHS data dictionary has a bit of a reputation for being used for commissioning data sets and feeding the beast rather than clinical systems. So presumably we're going to see improvements, and you can see where I'm going with this.
I can, and it's entirely the NHS data dictionary is, as you say, something which is very good at secondary uses of secondary care data that are not desperately related to the delivery of care to the patient. And my goal is to make it a health and care data dictionary that works for healthcare and social care, the delivery of healthcare and social care, the planning of healthcare and social care, the regulation of health and care and social care, and the delivery of health and care. To do that, it needs a complete change in its focus, but it can't lose its current capabilities in terms of we have 50,000 people a month reading the data dictionary, and they're doing that so they can do secondary uses of secondary care data. And you just think about the consumption of a product like HES out of the NHS Digital. People just depend on those definitions in the dictionary, and it just empowers the whole of the health and care system to do so much. Not in the most efficient way. I don't think anyone would claim that the secondary uses data flows are efficient and not always effective, but they are the best we have. So it's a case of keeping the existing data flows whilst changing the underpinning model. And I recognize that as one person today described it, it is changing the engine on an aeroplane while it's still flying. But the way I like to think about it is actually changing your underclothes without actually taking off your main clothes and keeping the facade of everything the same, but changing everything that's underneath. And that's going to be a very difficult challenge. The first step of that happened probably about 18 months ago now, when the data dictionary became the new website that is available. And that is now in a computable form rather than just in an HTML form. And the goal is that we've got full API access to the data dictionary probably within the next 6 to 9 months.
Excellent. Well, I never thought I'd be in a BPM webinar where we got changing your underclothes without taking off your outer clothes as an analogy, but there's a first time for everything, isn't there? I
do like to challenge things. So I think I've got one of the very few ISO standards which has got the word desire in it too.
Right, okay. Pleased to hear it. Now, there aren't any more questions in the chat, and it's 5 to 7. So unless something crops up in the next few seconds, I think we're going to draw this to a close. I'd like to reiterate that I thought that was truly outstanding, Nicholas, genuinely so, in many ways. And I hope everybody else found it as worthwhile as I did.